Welcome to AETCM, the Emergency Medicine Channel. Today I'll be presenting a case of a 64-year-old male who presented to our ER with complaints of fever, lethargic cough with associated breathlessness. On 10-second initial assessment, patient is conscious and oriented. On our primary survey, airway was patent. There was no gurgling sounds of stridor. Breathing-wise, air entry was bilaterally equal. There was minimal wheeze was present bilaterally, and saturation was 90% on room air and respiratory rate of 26 per minute. At this point of time, we had started the patient on oxygen via nasal prongs 3 liters, and also we had given a nebulization of duolin, which is salbutamol and ipratropium bromide nebulization was given. And circulation wise, pulse rate was 120 per minute, and BP of 100 bar 70 millimeters of mercury, and capillary refilling time of 2 seconds. Disability wise, GCS was E4, V5, M6, and pupils equal and reacting to light 2 millimeter, and no focal neurological deficits are seen. And GRBS wise, it was 130, and exposure temperature was around 102 degree Fahrenheit. This point of time, we had placed an 18 gauge IV cannula, and we had given injection paracetamol 1 gram IV stat. And we had reassessed again primary survey, and saturation has now improved to 98%, and we had continued with the 3 liters. And coming to the adjuncts of primary survey, ECG was taken, which showed a sinus tachycardia. And ABG wise, pH was 7.38, PCO2 45, PO2 of 64, a mild hypoxemia was there, bicarb of 28. Coming to the history proper, 64-year-old male presented to ER with complaints of fever with associated chills and rigors, and he also had associated cough with white scanty sputum and associated breathlessness on exertion, mainly MMRC grade 2. And there was no associated orthopnea or PND. And he was also went to outside hospital for the same, and he was tested positive for dengue NS1. And he was there he had thrombocytopenia, and they had transfused around 5 pint platelets. RDP was transfused outside. There was no other significant history. No allergies to any medications, and not on any medications as such. Past history of one extrapulmonary cervical TB was documented in 2003. On examination wise, there was air entry was bilaterally equal, but there was wheeze was present bilaterally, and minimal crepitations only in right basal, left basal was there. And the rest of the things we had done, rest of the examination findings was normal. SNS2 was normal, no murmurs were heard. Abdomen wise also soft and non-tender, and CNS wise also no focal neurological deficits. And we had done X-ray for the patient. At that point, it showed bilateral haziness in the X-ray, and more in the lower part, mid and lower zones, and there was hilar prominence with the prominent bronchovascular markings. And further, we had checked for the platelet count. It was 12,000 at that time. Since in the view of underlying infection with thrombocytopenia, we had planned for a half pint SDP or 4 pint RDP transfusion. And that time he was maintaining 98% with 3 liter O2 with a respiratory rate of 24 per minute. Minimal tachypnea only was there. And further, we had started on nebulizations, and antibiotic doxycycline was started. CRP was only 22 at that time. And total counts were 6.4. There was no other organ dysfunction. Creatinine was normal at 0.6, and LFTs also only OTPT was mildly elevated with 150 80 OTPTs. The rest all parameters are normal. Then we had planned to transfuse platelet of half a pint STP, which was available, and post transfusion initially during transfusion he was fine. We are monitoring his vitals during the transfusion. It was stable, and also there was no any fever spikes during the transfusion, and urine catheter bag also, it was clear urine was being drained. And after that, 2 hours later, post transfusion vitals was also normal, the initial vitals, and then after 2 hours the patient has started having acute onset of worsening of breathlessness, and we had again reassessed the patient. That time the saturation was dropping to 90% again on 3 liter O2, but the tachypnea has increased prominently, and it has increased to around 36-38 respiratory rate. And BP was stable on lower side, but 160, but BP was stable, and Pulse rate was, patient was a bit agitated, and tachycardia was there, 126 rates per minute rate was the pulse rate. And after that, we had went ahead with the auscultation. Auscultation, it showed wheeze was there, minimal wheeze was there, but there was diffuse crux, full upper zone, the infrascapular, mammary, inframammary, infraaxillary, almost all areas there was diffuse crux was present, but only that minimal volume only we had transfused for half pint STP. And further we had planned for a chest X-ray. Chest X-ray taken showed worsening of the previous X-ray. There was worsening of the haziness. There was full upper zone, mid zone, and lower zone complete infiltrations, haziness, scattered, non-homogeneous opacities was there. Bilateral non-homogeneous opacities was seen in X-ray. And from that point, we are suspecting something related to, it can be either due to a transfusion related reaction is what we are suspecting because of the acute onset of symptoms post-transfusion. So, and also we are having a differential of either it could be a transfusion related acute lung injury or a transfusion associated related circulatory overload. But since the volume we transfused was minimal, we are more thinking in terms of transfusion related acute lung injury. And we had changed the patient to BiPAP because of the tachypnea and axillary muscle use. We had changed to BiPAP, and we had placed a 12/6 rate. And further, the patient also we had given Lasix also, 20 mg IV stat was also given. Since BP was already on lower side, only minimal Lasix bolus we had given, and we had started on infusion as such. We had started on 6 mg per hour IV infusion. And then patient started to progressively improve, and the crepitations also started to reduce, and further repeat X-rays were also showing improving trend only. There was not the haziness started to improve.
So this patient's presenting complaints were not related to the complication as such. No, patient presenting complaint was fever with generalized tiredness and lethargy. With outside thrombocytopenia. So fever with thrombocytopenia. But on arrival itself, he told patient was having breathing difficulty. Okay. Now, fine. Transfusion related reactions. Transfusion related reactions is very important from an emergency viewpoint, because if a patient not only for admission, if at all our patient gets some blood products from chemo room or any transplant room also, patient can develop these symptoms and can be shifted to emergency department. So we need to know. So let's briefly enumerate what are the most common transfusion related complications.
We can divide it into non-life threatening and life threatening. Non-life threatening, we have the febrile non-hemolytic transfusion reaction.
Correct.
And then we have the allergic reaction, the usual allergic reaction. Those are the major non-life threatening. And life threatening wise, it will be the allergic reaction can become anaphylaxis.
Okay.
Then there can be hemolytic transfusion reaction. And then we have this transfusion related acute lung injury and transfusion related circulatory overload.
Okay.
Those are the main.
Yeah, and transfusion related sepsis. So these are the most common life-threatening conditions. So life-threatening conditions of transfusion-induced reactions we should be knowing. So this patient's history is very clear. Patient was already transfused outside with 4 pints of platelets and was referred here. Here also, since patient's platelet levels were not low, we decided to transfuse with half a pint of SD. Now the question is, what is the minimum quantity required to develop a transfusion-related reaction? Is there a minimum dosage that is needed, minimum dose of transfusion needed to develop a reaction? No. Patient can develop transfusion related reactions on the first chance or on the second or even third transfusion attempt. Okay, it's not like first time patient didn't develop, so patient will be immune to it. It's not like that. Second of all, patient can develop transfusion reaction on even half a pint of blood product or even 4 or 5 pints of blood products. But even though that is the case, what are the most common risk factors for developing transfusion related reactions? Past history of reaction. Good. That is first and foremost is past history of reactions. Then autoimmune conditions. Then
Then if the patient is having an underlying risk factors for, like in this case, LRTI, like that, any infection, they'll have in
recipient risk factors, right? Recipient risk factors of ongoing sepsis,
a shock in
shock,
hypotension.
severe shock states, any other inflammatory conditions. No? We will come to
Inflammatory
that.
conditions, trauma, severe trauma, severe burns.
No, we will come to that thing because that heading will be confusing if you say here. Okay, but basically patient-related and amount of blood products. So the more the amount of blood products, more probability is there for the patient to develop transfusion. But patient can develop transfusion within 1 pint of PRBC or plasma also. Now, so we told risk factors for this. Now, what about what are the common byproducts of blood or blood products that can develop reactions, especially transfusion associated lung injury?
Most commonly, based on incidence wise, we have platelet concentrates are the first most commonly causing the transfusion-related acute lung injury.
Okay.
And then comes the plasma, which has more of those anti-HLA antibodies.
Okay.
So in those cases,
so actually, all blood products can develop TRALI. The answer is all blood products can develop TRALI. You can develop from PRBC transfusion, FFP transfusion, platelet transfusion. It can be also due to granulocyte transfusion, stem cell transplant. All these things can develop TRALI. But the most common causes are FFP and platelet transfusion. Okay. So all this is with a percentage of around 0.1 to 0.2 percentage in 10,000 patients. So it's not very common findings, TRALI and TACO. So the TRALI is transfusion related acute lung injury and TACO is transfusion associated circulatory overload. Okay. Rather than hemolytic transfusion reactions, these two are much more rare conditions, but we need to keep in mind. So we told epidemiology as such and about causes and risk factors. Now, in this case, you are telling that post-transfusion, after 2 hours, patient started having breathing difficulty with desaturation on oxygen therapy. But patient was already having breathing difficulty, right? How can you say this is transfusion related? Why can't it be infection-induced lung parenchymal pathology like pneumonia, a worsening pneumonia? How can you say this is transfusion?
We have diagnostic criteria for that.
So what is the definition of TRALI or TACO?
TRALI is the acute onset of worsening of breathlessness following blood product transfusion due to mostly immune-mediated immune-mediated cause.
That is pathophysiology. Basically, post-transfusion acute lung injury or ARDS-like features within minutes to up to 6 hours post-transfusion is the definition. This is by Canadian Consensus Conference, right? This is by CCC definition. Now we have a much more newer definition in 2019, but which is a bit more complicated. But basically, post-transfusion or during transfusion, within 6 hours of a transfusion episode, if patient develops acute worsening of breathing difficulty, where, what is the exclusive content here, where patient doesn't have features of ARDS or
risk factors for
ARDS or cardiac dysfunction. So you have to rule out a acute LV failure and ARDS. So previously, to say TRALI, you have to make sure patient doesn't have ARDS, existing ARDS, and new onset acute LV failure has to be ruled out. These are the 2 exclusion criteria you need to do. But TRALI is divided into 2 criteria, right? TRALI class 1 and class 2. Yeah, TRALI 1 and TRALI 2. So TRALI 1 is the current definition that we just told. It's a pure transfusion related reaction without cardiac failure, without ARDS. But what about this patient? This patient on arrival itself is having breathing difficulty, isn't it? So you having got a X-ray, your getting the X-ray, right? So you may not be able to know whether patient is in ARDS or not, isn't it? So some patients may be ARDS. Some patient may be having severe sepsis, severe pneumonia or ARDS-like features. Those patients can also develop TRALI after transfusion. So how will you differentiate that? So that is based on risk factors for ARDS. So first thing, you should not have direct ARDS diagnosis, but you can have, patients can have risk factors for ARDS. What are the risk factors for ARDS? You were telling earlier.
Sepsis,
Severe sepsis,
severe trauma,
severe shock states,
trauma,
multi-trauma, multi-organ dysfunction or multiple trauma in this thing.
severe
Burns, intoxication of chemical, inhalational agents, then massive transfusion as such, massive transfusion. So these are the risk factors, aspiration, progressive pneumonia. These are the risk factors for development of ARDS. So such risk factor patients are there who developed acute worsening post transfusion. You can take it as possible TRALI. Those are called as possible TRALI. So that is TRALI 2. So TRALI 1 is definitely TRALI. There is no previous respiratory complaint, but after transfusion patient developing respiratory complaint. That is TRALI 1. But there should not be cardiac failure or ARDS. Second one, patient has some problems. Cardiac problem is there or ARDS risk factors are there, but you are not 100% sure it is ARDS. So basically we are telling TRALI 2 is a mix of respiratory complaints plus transfusion related acute worsening. Okay. Now, even though all this is there, we have to suspect a TRALI probability post-transfusion patients. Now, what are the clinical features in which patient will present with the TRALI?
In TRALI, they'll present with basically a worsening of breathlessness mainly.
Okay.
And then patient can present in
so it's basically tachypnea and respiratory distress.
Then hypotension related.
That is there, but we are saying about respiratory, right? Tachypnea, respiratory distress, so hypoxia, severe hypoxia. Okay, then PaO to FaO2 ratio?
Less than 300.
Less than 300. Usually it is severely hypoxemic, so SpO2 less than 90 or PaO2 FaO2 level less than 300 can be seen. Then?
And then on X-ray, we have to see for bilateral diffuse infiltrates.
Yes, bilateral diffuse fluffy shadows or infiltrates can be there, seen in chest X-ray as such. Then
it should be acute onset, less than 6 hours as you said.
Correct. Then what you told, patient can have fever, patient can also have hypotension, right? Yeah. So patient can have hypotension or fever, but this hypotension and fever is mainly due to inflammatory reaction. Okay, so these are the clinical findings of TRALI. Now, how does TRALI occur? What makes a patient prone for TRALI?
Basically, if the donor plasma, it contains antibodies such as the anti-HLA antibody, human leukocyte antigen antibodies are there. Then while transfusion, it can attack onto the leukocytes and it can adhere to the vasculatures, pulmonary vasculatures, and that will cause mediators to come and increase the vascular permeability.
Exudative, right? Inflammatory response, correct. But we transfuse blood for many number of patients, no? Like TRALI and TACO occurs in very, very small amount of patients. So why those patients? So my question is it blood product related or is it recipient related complication?
Depends on recipient also, if he has risk factors.
So it's basically a recipient related complication. Now, anti-HLA antibodies can be seen in many blood products. We don't screen for that when we take blood donation. Okay, most of the patients do not get triggered for TRALI even though HLA antibodies or HLN antibodies are there. They don't get triggered mainly because their signals are too weak for neutrophils to care for them. But in a patient, it's called as two-hit method, right? So pathophysiology of TRALI is like a two-hit method. So basically we are telling a recipient who is primed for immunological reaction. Basically, the neutrophil activation is the primary mechanism in which TRALI is being produced. So, a patient, recipient patient who is already having an acute inflammatory primed state. So, the neutrophils of this patient is very highly sensitive to a new antibody coming or antigen coming. So, those neutrophils are ready for activation. So, those neutrophils is the primary hit. So, this is mainly seen in sepsis, multi-organ dysfunction, severe cytokine reaction states and all. So, neutrophil activation should be ready. And when such a patient is then transfused with the blood product which contain HLA antibody or HLB antibody, these neutrophils get activated and neutrophil sequestration happens, and neutrophil will release interleukin 8, AETCM necrosis alpha and all, causing microvascular exudative shift into the alveoli parenchyma. Okay, so but basically it's a recipient mediated reaction more than a blood product mediated reaction. Why we have to mention that? Because if it is a blood product mediated reaction, the treatment is going to be prophylaxis. That means screen the people who come for blood donation so that don't take blood from people who are prone for starting TRALI. Now that is there in comparison to previously. Now TRALI has completely come low, significantly reduced due to their screening for certain individuals who has previous episode of TRALI when transfused with their blood. But we cannot expect that because patient itself can be a risk factor for TRALI. Now, after pathophysiology, we told clinical presentation. Now coming to treatment part. So, how do you approach a patient with post-transfusion related acute lung injury? What are the things that you will do?
First of all, we'll have to correct for the oxygenation.
Yes.
So given, and if the patient is still tachypneic, then we'll have to start on pressure ventilation.
But first, positioning of the patient, right? You have to put the patient on a head and
30 degree head and elevation.
Yes, and start the patient on supplemental oxygen. We have to identify this is a hypoxic problem. Now the hypoxic grades will be mild, moderate, severe, and accordingly we will have to use our airway accessory devices or ventilatory devices. So as you told, first oxygen therapy, and in moderate to severe cases, we may have to put the patient on positive pressure ventilation, as a CPAP or a BiPAP may be required, and titration of values need to be done. And in severe cases, PaO2, FaO2 ratio less than 100, you may even have to
intubate and ventilation.
Endotracheal intubation and ventilation has to be done. But basically, a supportive care for maintaining oxygenation should be done for the patients. Okay, what else?
Then if the patient is in hypotension, we'll have to support with inotropic support.
Correct.
Or if we are able to know about the fluid status of the patient, then depending on that, if the patient is not in cardiac failure, then we can supplement with fluids.
Correct. So like any other hypotensive patient, we have to know about cardiac and renal condition. If cardiac and renal is normal, we can give IV fluids. But the problem is, you have to make sure patient doesn't have transfusion associated circulatory overload. That is a close differential diagnosis for TRALI. So if you say transfusion like massive transfusion, multiple 4 to 5 pints of PRBC is done, or more than 8 pints of FFP is done. So if you are transfused significant amount of volume to the patient, the volume overload can cause fluid overload features, and that associated with you giving more fluids for correcting hypovolemia or hypotension can complicate cardiac status. So transfusion associated circulatory overload should be ruled out, and patient should not have a cardiac and renal dysfunction. If not, first management of hypotension is, as we all know, 20 ml per kg of IV fluid bolus you can give, and if no improvement, early inotropes can be started because this is an immunological reaction. You require inotropic support. Okay, so hemodynamic support for circulation has to be done. What else? It's a pulmonary edema, no? So why not?
If you are suspecting a TACO or transfusion,
in TRALI, this is a pulmonary edema, right? We are telling it's a pulmonary edema. Why not give furosemide? Why not give loop diuretic?
Furosemide we can give if it is secondary fluid overload we are suspecting.
Yes. So,
But if it is
so basically, TRALI is a non-hydrostatic. It's a immunological pulmonary edema, right? So it's not a transudative pulmonary edema. It's a exudative pulmonary edema. So furosemide is not going to act in TRALI patients. So furosemide is not indicated in very clear TRALI patients, like TRALI class 1 patients. You don't have to give furosemide, but TRALI can coexist with organ failures or transfusion associated circulatory overload. So in transfusion associated circulatory overload, you can give furosemide. Okay. Now, so we are saying that it's a immunological pulmonary edema. So furosemide is not useful. It's immune mediated. So what about steroids? Can we give steroids?
if patient is further worsening, then we can give trial of steroid can be.
Okay. So steroid treatment as such, is it recommended?
Not there recommended.
It's not recommended because as we told, there is TRALI class 2, which is TRALI in patients who has risk factors for ARDS or already existing mild ARDS. And hydrocortisone or steroid therapy in ARDS is highly controversial because late onset complications of ARDS is proven secondary effect of steroid use. So, since that mixed condition can happen, steroid use should be very conservative. If you are 100% sure TRALI is there and you have given all supportive management, and if patient is worsening, you can try with steroids, but it's not recommended. Okay, so furosemide and this thing is not recommended in pure TRALIs. Okay, then what else? How long will you treat this patient? If a patient, you are saying that patient came with TRALI, you are given these medications, but the patient worsened and you have intubated. So, how long are we expecting TRALI to persist in the body?
For around 48 hours.
Yes. So, usually TRALI is acute immune mediated, but it's a short-lived immune mediated. It's not like patient is going to be on ventilator or symptomatic for next 1 week or 2 weeks and all. It's not ARDS. So, if patient persists to have symptoms more than 48 to 72 hours, you should suspect other lung pathology. Like ARDS lung pathology, you should suspect. Usually TRALI resolves with treatment within 48 to 72 hours. Correct. So TRALI part we have taken, right? So we were talking about TRALI and TACO, right? Transfusion associated circulatory overload and transfusion associated acute lung injury. What is the difference between these two?
One is basically we have discussed about immune mediated
pulmonary edema, and the other one is
more of fluid
overload. Transfusion transudative pulmonary edema. Second is
based on the difference. You can say it as like BP wise. One will have hypotension, other one will be having hypertension.
So TRALI will most probably have hypotension because immune mediated can cause inflammatory hypotension. And usually TACO is usually associated with
fluid overload and hypertension.
Elevated systolic BPs is usually seen in TACO. Yes. In TRALI, what else can be there?
Temperature wise, there will be fever and all in TRALI, but
inflammatory. So fever can be there. And TACO?
TACO, it will be either normal.
Usually normal or peripheries can be even be cold, isn't it? Okay. Then what else is there?
Then we have this Lasix responsive or not.
Yes.
TRALI is not Lasix responsive.
Yes.
TACO is
furosemide. Loop diuretic response. Since it's fluid overload and if your kidneys are working fine, you give furosemide. TACO will come down much faster, but TRALI may or may not respond. It usually won't respond. What about cardiac status?
Cardiac hypertension more likely in TACO.
Yes, so acute LV failure, left atrial hypertension, pulmonary artery wedge pressure is usually normal in TRALI and elevated in TACO. These are the most common differentiating features.
NT-proBNP will be raised.
Yes, correct. So, cardiac NT-proBNP will be elevated in TACO and TRALI can be elevated because inflammatory condition, NT-proBNP is an inflammatory marker, can be elevated but not as much as a TACO case. Okay. So, this is basically the differences, common differences in which you can use to identify a TACO versus TRALI in a patient, right? Okay. So, if a patient comes to post-transfusion comes to ER and patient is having worsening breathing difficulty, maintaining on oxygen, with 5 liter oxygen, 3 liter oxygen, patient is maintaining saturation and all. Do you want to go with NIV or ventilator and all?
Based on if the patient is using axillary muscles or tachypneic.
No, not in respiratory distress. Not in respiratory distress. You don't want to, right? You can give supportive management, and NIV, positive pressure ventilation, is only for respiratory distress or refractory hypoxemia. Not all patients is not required to be put on BiPAP. Patient can be managed with the oxygen, supplemental oxygen itself. Anything else to add?